Good morning, everyone, and welcome to this live seminar series offered jointly by UW Medicine and the Whole U at the University of Washington. My name is Annie Kuo, and I am the Director of Marketing Communications in the Department of Obstetrics and Gynecology at the UW School of Medicine. It's been a very busy time for the clinical faculty in our department, as it's been for medical professionals across the world in adjusting to this new reality of providing healthcare during COVID-19, especially with Washington being an early site for US cases. So we're extending the seminar today to our patients and the broader public to offer comfort, support, and guidance around pregnancy and the novel coronavirus. And our service line, the Center for Women and Children, hopes to continue offering this direct support from our experts through another webinar in the next couple weeks with pediatrics faculty on newborn care and COVID-19. So some friendly reminders. If you're just joining us live, please make sure to turn off your personal video and volume so that we can focus on the panelists who will be presenting and addressing questions today. Please keep your video and sound off for the duration of this seminar, as I will read the chat room questions to the panelists directly. Our plan today is to cover frequently asked questions, including many that you've sent us, and then spend the last third of our time together answering questions from the chat room. We will also be joined later in the session by Dr. Christina Adams-Waldorf, a UW professor of OBGYN and global health who is researching COVID-19's impact on pregnant and postpartum women. To participate in our study, you can go to the link shown on this slide, bit.ly/UW COVID pregnancy. Now I'd like to introduce our moderator, Deborah Blue. She is a certified nurse midwife stationed at the Northwest Midwives Clinic, delivering babies at the Childbirth Center at our UW Medical Center Northwest campus, which was previously Northwest Hospital until 1/1/20 this year. We have midwifery groups at both campuses, Northwest and Montlake, and Northwest is actually renovating their Childbirth Center in stages to open with some spacious upgrades in 2021. This image that you see here is from a recent feature in Pacific Northwest Magazine, which is part of the Sunday Seattle Times. If you have some time while staying at home these days, please check it out online. And so with no further ado, welcome, Deborah. Thank you for leading this discussion, and please go ahead.
Thank you, Annie. I'm so pleased to be here today for this discussion. So hello to all of you out there in the greater UW medicine community, and thank you for joining us. As Annie mentioned, I'm a certified nurse midwife at the UW Midwives Clinic at the Northwest Hospital campus. In our practice, there are 6 midwives in total, and we are a group practice. This means that patients have the opportunity to meet each one of the midwives throughout the course of their prenatal care. And we do this because we found that patients really appreciate the opportunity to meet whoever may be with them in the hospital when they go into labor. So whichever midwife is on call on the day that someone goes into labor is the midwife who will be with them when they have their baby. We're a very tight-knit group, and we strive to develop close, trusting relationships with all of our patients. Most of our patients come back to us if they decide to have another baby, and we really value that continuity and sense of growing community. So what have I seen over the last 2 months or so of this pandemic? I have seen a significant increase in worry, and understandably so. Whether a patient is pregnant, postpartum with a new baby, or just considering whether to become pregnant, this pandemic is factoring into everything. Pregnancy at its baseline is a challenging time for most people. It is already a time of increased worry. In pregnancy, we just so want everything to be okay. Pregnancy is packed with information. It demands a lot of decision making, and ultimately it is a time of trying to come to terms with some degree of uncertainty. So to put all of the unknowns of the COVID-19 pandemic on top of an already vulnerable time, it feels like a lot. One of the things that's particularly challenging for patients, and all of us for that matter, is trying to keep up with all of the latest information. It's an understatement to say that this is a moving target. We here in Seattle were thrust into what really was the first epicenter of COVID-19 in the US, and that happened almost overnight. We have been incredibly fortunate to have the leadership of our institution, UW Medicine, which is proving to be on the forefront of the science regarding COVID-19. We were the first in the US to start drive-through testing, one of the first to implement universal COVID testing for labor patients, and now we have a rapid 2-hour test. These things are game changers. And at UW Medicine, we're committed to keeping patient safety at the forefront. We are still learning, and recommendations are continually changing, but we are making strides forward. And I'm incredibly grateful to be part of a team whose mission is to share what we're learning. So the intention of today's discussion is to present the most accurate, up-to-date information that we can about the novel coronavirus and pregnancy, to talk about some of the things that we're finding and experiencing with our patients, both in clinic and in the hospital, and to share what we're learning with you, our UW community. We want to be transparent about what UW Medicine is doing to protect patients. Prenatal care is evolving as we speak. Telehealth is adapting to meet patient needs and maximize safety, while at the same time maintaining access to care. And in terms of the hospital experience, there are new policies and restrictions, and we recognize that these can impact the experience of birthing families. And we want to talk about those. So, thanks you to all of you who have sent in questions prior to today's discussion. And as the discussion continues to unfold, send us your questions as they arise, and we will do our best to get to as many as we can. We are here for you, and we are in this together. So, without further ado, I'd like to introduce our panelists. Dr. Suchi Sekaran is a maternal fetal medicine specialist who practices at the UW Montlake campus. Along with Dr. Sandrika-san is Dr. Alisa Kachikis, and she is also a maternal fetal medicine specialist at the UW Montlake campus. And Dr. Anna Shope is an OBGYN who sees patients at the UW Shoreline Neighborhood Clinic and delivers babies at UW Montlake. So welcome to all of you. Dr. Chandra Sakazan, can you tell us a little bit about your practice?
My name is Dr. Suchi Chandrasekaran. I'm part of the Maternal Fetal Medicine Division at the University of Washington. And that means I take care of moms with underlying health conditions during their pregnancy. We're all here and we know that these times are very anxiety provoking, and so we're here to answer all the questions that we can and help people out.
Great. Thank you. Dr. Kachikas, do you want to go?
Yeah. So I'm also a faculty member in the Maternal Fetal Medicine Division in the Department of Obstetrics and Gynecology at University of Washington, which means that I take care of high-risk pregnant patients too. And I think for all three of us on this panel, at least at the Montlake campus, we've all been involved in taking care of pregnant women now who have been positive, have infections with COVID, and then also been part of kind of the screening and treatment algorithms for women. So again, I agree, it's a little bit anxiety provoking, and I think coming in at such a vulnerable time in life, coming in to give birth and be told that there are restrictions or that things need to be a little bit different is always a little bit unsettling, but we've all been kind of part of this, and we're trying to make this as smooth of a time as possible, especially for pregnant and delivering moms.
Yes. All right. Thank you. Dr. Shope.
Hi, so I'm an OBGYN generalist, which means I do general OBGYN practice, and I'm primarily at the Shoreline Clinic right now, and then I do surgery and my patients deliver at the UW-Montlake campus, as you already noticed. And I think one of the things that I wanted just to mention in the intro is how much we have really protected prenatal care, and that we think that's an essential service, but we've really been adapting it. And you've already mentioned, Deborah, the telemedicine program, but that's, I think, something to be really proud of, that UW Medicine was really kind of first in our region for doing, where we are loaning patients Dopplers and blood pressure cuffs and able to give virtual visits where they actually get to check on their own pregnancies and their bodies themselves while we can be remotely talking with them. And I think it's a really nice way to incorporate safe practice for our patients. I think that's been really nice. And I think that, you know, as everyone else has already mentioned, we're working really hard to keep our patients updated as everything evolves. And we're really committed to keeping our pregnant patients safe and their babies safe.
Yes. Okay, well, thank you all for that. So we thought we would start out by just covering some general questions, getting some information out there to begin with. And as it makes sense, I'm gonna weave some of the questions that we got ahead of time from our listeners, and then Annie is also going to cover more questions as we go along. So to start out with, it's a kind of a broad question, a broad topic, but Dr. Kachikas, could you start us out with sort of a general description about what we know so far about COVID-19 and pregnancy?
Yes, and I'm gonna start just by kind of rehashing a little bit about COVID-19, just so we're all on the same page in terms of what we know about the virus in general. So COVID-19 is caused by a coronavirus, an RNA virus, and it is very similar to two other viruses that we've seen in the past. One caused SARS, and the other one caused the Middle Eastern Respiratory Syndrome coronavirus. And so this is a virus that is mainly transmitted by respiratory droplets, so drops. And then in very rare circumstances, it can become aerosolized, and that's usually in medical conditions. Incubation is around 5 days. So after you get the virus, it may be about 5 days until you start having symptoms, but it can range anywhere from 2 to 14 days. So that's why we're seeing a long time of just precautionary measures. When you hear in the news that people are quarantined for 2 weeks, that's why. So when we don't have a lot of information on COVID-19 in pregnancy, and that's that coronavirus disease 19 in pregnancy. From our past data, so our experience with SARS, for example, and influenza, which is a different respiratory virus, we have a little bit of information on the fact that respiratory diseases caused by SARS can result in severe disease in pregnant women in some cases. And influenza in general can cause problems in pregnancy for both the mom and for the fetus. And so we're always a little bit cautious when it comes to respiratory disease and pregnancy in general. In terms of COVID-19 and pregnancy, what we know right now, and this is kind of the research aspect of it all, we have case reports, which is basically a report that a scientific community puts out, or a few researchers, about a case of COVID-19 in pregnancy. And then we have case series, which is a kind of a small collection of cases, and these cases are then summarized to kind of give an overall description of these small groups of women. So we don't have a lot of evidence right now, but we know from small reports from China, and then there have been some reports from New York coming out. Also, we're working on research at the University of Washington, which will hopefully be out soon too, on COVID-19 and pregnancy, and Dr. Adams-Waldorf will be talking about that a little bit later on. But what we know is that in general, a lot of the range of disease can go from asymptomatic to mild disease. Mild respiratory disease is kind of like having a cold, maybe having a fever, more like the flu. But then there are some cases that can still be severe in pregnancy. So that so much so that we have to kind of bring a pregnant woman in with COVID-19 and kind of watch her in the hospital. And there have been some cases also of more severe disease, which means watching women in the ICU and kind of supporting the respiratory status that way. But in general, women tend to do okay in pregnancy, but we're very cautious with that knowledge. For women who do end up having COVID-19 in pregnancy, we end up doing a lot of telephone calls if we're able to keep women at home or follow them closely in the hospital. The CDC, when they talk about pregnant women who have COVID-19, call them, quote, others at risk. So they're not in the highest risk population, which tend to be the elderly or people with pre-existing conditions, but they're still at risk. And then the other caveat to what I just said is that people with underlying conditions should just be extra cautious, pregnant or not, during this pandemic. So it sounds like pregnant women overall are doing okay, but we just want to be very, very careful and watch them closely.
Yeah. Okay. I think that has been a question on a lot of women's minds, of fearing that pregnancy makes them more vulnerable, and why. And so it sounds like we're cautiously watching to see if that's holding true for this, but it doesn't appear yet to be as bad as we might have worried. Is that right?
Yes, there can be severe cases, and we just want to be very cautious in saying that women overall, though, tend to do okay. More like the general population. But again, just because of changes in pregnancy and depending on the underlying conditions, it can result in severe cases.
Okay, thank you. So another question that is sort of related to this is, what are the thoughts about whether the coronavirus is transmitted in utero? Does it cross the placenta?
This is all part of this data gathering phase right now. There is no clear, concrete evidence that the virus crosses the placenta, and there are always these questions about cross-contamination or not. But from my understanding, based on the research that's been published, babies that have been swabbed after birth have been, in general, negative. So there are institutions and researchers looking at whether it can cross the placenta, but there's no clear evidence that that's the case yet.
Mm-hmm. Well, so far that sounds really reassuring, and we just have to keep gathering more data. Dr. Shope or Dr. Sandra Sekazan, do you guys have anything to add to any of what Dr. Kachika said regarding that?
No, actually, and I just would like to echo Dr. Kachika's thoughts that it is all still preliminary. So the good news is we start with kind of the baseline of what we see, and you know, one thing that's advantageous to us is this is not in a good way, but this is a worldwide pandemic, right? So we're getting data from so many different regions, and overall, it doesn't seem that pregnancy, like Dr. Kachika said, is as affected as it could be. But again, and the what we call vertical transmission, or mom to baby, that doesn't seem to be as clear, which is good for us to know. But it's all still really early, and I think that's just important for all of us to keep in mind as we keep gathering our info.
Yes. Okay, thank you. So Dr. Sandra Sekazan, can you tell us what precautions is UW Medicine taking for its patients? There were a lot of questions kind of around this general topic.
So I think, you know, it's good to talk about the precautions, both from the patient side and also from the provider side, because again, we want to be safe for everybody involved. So from the patient side, I would say UW gets a lot of credit in, you know, having been very proactive in one of the first places having to deal with this and really thinking outside the box and how do we make patients feel safe and get the care they need. So kind of like what Dr. Shope said, you know, we have for our pregnant women, we had kind of started telemedicine even before this pandemic had started. And that ended up being quite advantageous for us because it allowed us to be able to continue that platform, but safely allow for women who could have that method of care given being done. As high-risk physicians, for Dr. Kachikas and I, oftentimes it's very hard to do that because we still end up needing to see the patient face-to-face for other things, but we're still able to modify and do that and do some visits by telemedicine, some visits in person. And the nice thing about that is we're decreasing risk for the patients coming into this particular environment. So I think that's step one from a patient outpatient side that we've been able to institute. The second thing we've done for patients is, and for providers both in terms of safety, is we screen everyone for planned admissions, planned deliveries, planned C-sections within 72 hours of their admission so that they have their status known before they come in, which is also good for them because if they are negative, they're allowed to have one support person with them. And so that's good for them to know. It's good for us as providers to know because it kind of modifies the, you know, personal protective equipment and what we do in terms of their care. So that's one thing we've been able to institute. That can be done in one of two ways. If they end up having a clinic visit within 72 hours, we do have capability to swab in clinic, but if they don't, we also have outpatient drive-through capability for that. So that's another thing that's been instituted. In terms of on labor and delivery, if for some reason somebody comes in labor, which obviously happens in pregnancy, we do swab our patients that may not have had that planned opportunity to get swabbed on labor and delivery, and that's universal for anyone we wouldn't know status for. And the nice thing is the University of Washington, both in terms of clinical care, but also in terms of research and testing, has been very cutting edge. And so we do have faster and rapid assays that can run and get us the data back, not in the standard 8 to 12 hours. So if they do come to labor and delivery in that amount of time, we are now having the capability to be testing folks and getting results back within 90 minutes to 2 hours, because we do run a platform every 2 hours for that. So I think from a patient care and safety side, these are all things that we're able to do to make sure patients feel safe and have data about themselves and what's going on. And then in terms of also providers, because I'm sure patients are wondering, are the providers safe and how does that work? You know, we are all, I think, being very cautious and careful. And we, in our department, we have questions to answer about our well-being to make sure we're okay to come to work. And then, of course, we wear our masks. And so we have masks available for us that we get. And therefore, we're protecting, you know, us from transmitting anything as well, given that there is an asymptomatic component to this. You know, I think providers have always been very careful about, you know, personal hand sanitation, but it's just something on our minds much more. We just see a lot more healing, all of that. So I think as providers, we're very careful and just much more hyper aware of that process. In terms of social distancing, of course, that's also being instituted to the best of our abilities in all of our environments and situations. For patients, it's a little easier in rooms to do that. For providers in some of our care areas, we've done small things such as take away a table so that we can fit enough people in a room safely with some social distancing. In clinics, I think we're all just much more aware in making sure that there is social distancing amongst our providers so that we are also safe and healthy to provide safe care for our patients. So I'd say there's many things that in the past month have been kind of just very quickly and efficiently instituted to keep it safe for the patients, the babies, and the providers.
Thank you. One of the things that you addressed in how we're working to keep things as safe as possible for patients is the limitation of one visitor. And there have been a lot of questions regarding why did we change from allowing a doula and a partner to only one partner? And I wanted to address the question around having a doula because I actually have a really dear spot in my heart for our doulas and their commitment to people, to birth. So we really appreciate the work of doulas, helping women and their partners prepare, being a steadfast emotional support throughout all of labor. They provide invaluable skills and help to families and for all of us. And so in normal times, we really welcome doulas into the hospital and encourage patients to have whomever they want at their birth as support people. And needless to say, these are not normal times. The decision to limit visitors to one person was a tough one as a department and as an institution. But it was done with patient safety and at the forefront. And basically, the intention is really just to limit the number of people coming in and out of the unit. And the restriction is intended to protect patients and staff together. And as you mentioned, it is consistent with the social distancing measures that we've seen, all across the board, everywhere, which just reduce risk of transmission by reducing exposure to people. And I just want everyone to know that we understand that it's really hard to have hopes and plans change. And yes, to answer questions about, are we reevaluating, will this change? As we have increased community testing, as social distancing measures are eased, and as we have a better sense of the trajectory of this pandemic, I think UW will be adjusting policies. And when that comes, we, of course, are going to be happy to welcome back doulas or additional support people. But now it felt like the safest thing for us to do for everyone. Dr. Shope, do you want to talk a little bit about questions sort of prenatally? One thing that's come up is, should I wait to get pregnant?
Yeah, I think this question has come up a lot, and I've actually been getting a lot of questions from my own patients I've known for years who are thinking about trying to conceive this year. What should I do? I have a patient who had her in vitro fertilization plan sort of halted and was trying to figure out, should I go back to that, and talking about it. And I think the most important thing, and this is not only my opinion, it's the opinion of the American College of OBGYNs, this is a very personal choice. So deciding when to have your family is something that you really need to think about as a family, and we want to help guide you and answer your questions, but it's not something that we should ever, and no one should ever say you should or shouldn't do. It's really your personal choice. I already said before, but just to reiterate, the prenatal care is essential. The birth process is essential, and the postpartum care is essential. So none of that will go away at all during this pandemic. So pregnant women can get all the care they need. It may be modified in terms of telehealth, but it's still the same prenatal care we had as before, just slightly different. And then I think the big thing that I think about a lot when trying to answer this question or help people is that it's a very stressful time right now with a lot of unknowns. Pregnancy itself is a time of unknowns, and so it's a matter of reflecting on your life and seeing how comfortable are you with some of these unknowns. And the things I think about are not necessarily just medical ideas, but what's going on socially, what's going on financially. Like, this is a very challenging economic time as well. And those things may influence your decisions. There is not any medical evidence to say that pregnancy should be avoided now. So that is not something, if you have heard, that is not true. That is something that is okay to pursue if that's right for you. And I think especially for some of our patients who are of advanced maternal age or have other high-risk conditions that really make the timing of pregnancy a little bit more pressing than other patients, it's really important to still go with your family planning wishes and not necessarily let what's happening now create too much fear to block your own desires and your own wishes. Like, we can be helpful and supportive for you. And I think the biggest thing is, if you have very specific concerns or questions, it's great to talk with your provider about that and sort of think about your individual situation and what their advice may be. So we do think it's safe to try to conceive if that is what you want. We have heard that in vitro fertilization will be restarting soon. And so these are things that are okay to do, and we're going to help you through it no matter what. I've been seeing like 5 to 6 new OB patients a week lately in person. We're still doing that care. So it's still can be very normal, even though everything feels abnormal right now.
Yes. It's a good point. There is something hopeful about babies still come despite pandemics. Well, Annie, I feel like we had a little bit more that we were going to cover, but we are, I want to get to the questions that have been sent in, and I think that in answering some of those, a lot of what we wanted to get across is going to come out. So do you think this is a good time to go to patient questions? Annie, are you there?
Yes, hi.
Hi.
Yes, I have been typing furiously over here on the side with lots of questions coming in, great ones too. I think this would be fine to transition to the questions. If Christina Adams-Waldorf makes it in to talk about her COVID-19 research, we'll introduce her at that time. Let's see, one of the first questions that I've got is a very practical one, and that is it safe to grocery shop while pregnant?
I can address that one if you want. That's one thing we haven't explicitly said, so I want to make sure we say it. It's very important that kind of all people, but especially pregnant people, should protect themselves from COVID-19 by doing very basic things we've all heard. The most important thing is hand hygiene, cleaning your hands with soap and water for at least 20 seconds, or using an alcohol-based hand sanitizer if you don't have access to soap and water at the time, and really being careful not to touch your face. So that's the most important thing. The other thing that has been recommended in the past few weeks is universally masking. And for patients who are not healthcare workers, or for people who are not healthcare workers, that can be done with a cloth mask. It could be homemade, it could be a bandana. And the idea is, if your face is covered, it prevents you from touching your face. So if your hands are contaminated at all and you haven't yet washed them, you won't have a risk of transmission if you're not touching your face, as long as you can then get to hand hygiene. So it is okay to go to the grocery store, I'd say, with social distancing, masking, and really good hand hygiene, if that is your only option. I know that grocery store delivery has been delayed quite a bit. And so if you have advanced planning, you could do things like that if you really don't want to have any exposures. But there are ways to do it safely if that is something you need to do, because we obviously all need access to food.
Great.
Great.
There were some of those about flying.
Yes, exactly. I was about to piggyback on that one with the questions about flying. This is both for pregnant women who may have an important essential trip to take. There were also questions about people flying in from other states, grandparents or other caregivers that the woman would like to have around the birth, or to help take care of other children in the home in the postpartum period.
Anyone want to volunteer for that one?
I have a comment on that, which is just to say, in our discussion this morning, what I didn't say is that all pandemics are a little bit different in different states. So what we're seeing here in Washington State is very different than what's going on in New York, New Jersey, and Michigan. So in terms of traveling to other places or having family members travel here, it's really important to be cognizant of different rates of viral transmission in other places and how many people are testing positive. So you may need to be either extra cautious traveling, or think about the fact that there could be some mixing in terms of community transmission rates. So just being very, very cautious about that.
Mm-hmm. And what we have seen, because we've had expanded testing, is that here in Seattle, at least, the social distancing measures seem to have been very effective. And because we're doing so much testing in terms of our OB patients, we've had a very low rate of positives. Is that right, Dr. Kachikis?
Yes, particularly compared to other states. So even if you look at the general population, our positive rate is much lower than what they're seeing in New York and Michigan, New Jersey, other states that are really hard hit right now by the pandemic.
Yeah. Okay, Annie, more?
Yeah, there's also a bundle of questions regarding regarding the safety of hospital births and clinic appointments. This might be a good time to introduce some of the telehealth programs that we have, and also address what precautions the hospitals are taking to both address testing of both clinical staff, others who may come in contact with patients, and then visitors who attend the laboring women.
Dr. Shope, do you feel like you want to answer that?
Yeah, I would say I think my clinic is an interesting one to talk about because it's a mixed clinic. So normally pre-coronavirus, we have urgent care, pediatrics, obstetrics, family medicine, internal medicine all here. And basically very quickly that shifted primary care to almost 100% telehealth, and our urgent care closed in order to protect our babies and our pregnant women. And so really the only physical people who are coming into clinic are the pediatric patients and my patients in this particular location. A lot of our other clinics have dedicated women's health clinics so that the only people coming in really are extremely urgent patients or pregnant patients. And then obviously our high-risk pregnancy clinic is all for pregnant women. So I think that the clinic is definitely very safe now. All of our clinics at UW Medicine started immediately screening patients at the door with large signs saying you can't come in if you have any of these symptoms, and gave a triage number to call and didn't allow entry of any patients with symptoms. And then since the universal masking recommendation, we do recommend our patients come wearing cloth masks. I wear a mask all day long, even if I'm just talking to my medical assistant or any patients. We're just universally masking completely to keep everyone safe. So I think that getting your care visits when they need to be in person, because even though we are really so proud of our telehealth program, some visits need to be in person for fetal monitoring, for testing, for vaccine administration. There are needs to be in person at times, and for ultrasounds. So I think that that's very fine and safe to do. In the outpatient setting, not associated with the hospital, partners can come to clinic, that's fine. And that's not an issue at all. It may be different in the hospital, so I'm not totally sure about that. And then I think what the next part was, is the hospital a safe place to give birth? Yes. We think the hospital is a very safe place to give birth, and it is completely secure in terms of who has entry to the hospital. There are no visitors allowed in the hospital, basically except for very high-risk patients, patients at the end of their life, and then our patients. So it's very limited who is getting to the hospital. All of the employees at UW Medicine across all the sites have to attest and sign a form that says that we are well to work, to try to eliminate any kind of risks for any sort of symptoms. Even if it's your allergy symptoms, we're asked to leave and go get testing and not come back until our test results return. So we are really committed to keeping all of our patients safe, and we do think that having a hospital birth is a safe place.
Thank you. One of the things I wanted to add just quickly to that is the benefit of testing in labor when women come in labor. It's what's great about it is that that test is coming back really quickly now, and once that test is back, then really women can proceed with a normal experience, and we really want to try to preserve that as much as we can in the midst of all of this. And so there were some questions about, does a woman have to wear a mask during her whole labor? Well, when COVID testing comes back and it's negative, then that really changes things, and no, she doesn't have to wear a mask. So Annie?
Yes.
Next.
Hi. Okay, I hear Christina Adams-Waldorf has joined, and she only has a few minutes, but some of the questions that we fielded, and I think that her video may be, here we go. Let's see. We got a couple questions that she may be able to address regarding whether any research has shown birth defects, the possibility of birth defects due to COVID-19, and if there's yet any differential data on how this impacts women of color. But first of all, Christina, would you just introduce the important work that you're doing? Christina has one of or the highest at the highest level of biocontainment laboratory in the Washington state. And she has been doing Zika research, but when this broke out in Washington, she immediately pivoted the focus of her research to study the impact of COVID-19 on pregnant women and their newborns. So tell us a little bit more about that and how some of the women on this call could participate.
Sure. I have always liked to study infectious disease in pregnancy, and I've been doing it for nearly 20 years. I've studied Group B streptococcus, which some women might know. That's something we test for in pregnancy because it can harm pregnant mothers and, most importantly, their babies. I've studied Zika virus, I've studied influenza virus, and started studying COVID-19. Done that both in the laboratory and also clinically and in big public health studies. So researched these types of things in many different ways. So a really good first question whenever there's a brand new virus is, could this harm the placenta? Could it harm my baby? Could it result in a birth defect? And that was one of the first things that we saw with Zika virus. I think that we've seen quite a few number of women that have been infected. We have not heard of birth defects, and I think that we would have if it was a virus that was similar to Zika virus. So I don't think that anyone who's researching COVID-19 in pregnancy is thinking about birth defects right now. I think that it would have been already clear to us that this would be a problem. So that's actually quite good news. We don't know about more other problems that might be a little bit more rare that the virus could cause problems for in pregnancy. And we worry about things like fetal growth and even stillbirth and how sick it might make the mother and whether she might need to have a preterm birth, essentially to help her breathe a little bit better if she became very ill. We're worried about all of these things, but we don't yet know how common they are. And so I'm working with investigators across 15 different hospitals in Washington state that are parts of the 6 biggest hospital systems in Washington state that are looking through medical records from women that have had COVID-19 in pregnancy so that we can try to get an answer in Washington state what is happening to pregnant women that have gotten COVID-19. And do we think that this represents an increased risk in any of these areas? And if it does, which women became sick? Are these women that have pre-existing conditions? What about completely healthy women that have a totally uncomplicated pregnancy? What can we expect for them? Is this an age problem? Is it being too heavy? Is it having asthma? Is it having high blood pressure, diabetes? We need some of these answers right now so that we can better take care of women and better predict who might become really sick. So these are kind of the very first questions that we need to tackle right now in Washington state. And I promise you we're working on it. We're getting really close to our first pass at a large number of women that have gotten COVID-19 in Washington state, and to be able to say something that we think will contribute to the public health conversation about this. I'm also really interested in looking at this in the laboratory because we can figure out better how this virus might injure the placenta or cross into the fetus. We have all of the laboratory facilities at the University of Washington ready to go to process some of these samples. So we are hoping that women that come in with COVID-19 that are unfortunate enough to be hospitalized with COVID-19 in pregnancy might be willing to help us and participate in these studies so we can better learn in the laboratory what's going on.
Thank
Thank you
you.
so much, Christina, for joining us. And I've added the link to her subject recruitment site in the chat room, and we'll also be emailing out a list of resources to you all along with this recording after later on today. Thank
Great.
you. Should we move on to the next question?
Sure.
Okay. There was an article in the New York Times that published a couple days ago, and it was about New York has a different situation now compared to where Washington State is, but it was kind of an alarmist piece about home births. And there's some questions that have come on regarding, this is a good piggyback question on what we were talking about earlier with the safety of hospital births, but is it a good time to consider a home birth? Can you provide some reassurance to all the measures that are taken so at the hospital so that folks can feel safe there, giving birth there, as opposed to pivoting to a home birth?
I can take that one. Yeah, the New York Times had that article. There's also an article from Philadelphia from Dr. Sindhu Srinivas at the University of Pennsylvania, also looking at just, in these current times of anxiety, that pivot from hospital to a home birth. And I'd like to emphasize from purely a pandemic safety and COVID safety standpoint, again, all hospitals in the area, and I speak for UW specifically, we've taken a lot of measures to make sure it's safe for both the patients and providers working, and providers being safe and not, spreading to patients, kind of all of those perspectives, decreasing the number of people in the hospital. And again, like Deborah said, that's hard because often the doulas and nurses can't come in, but actually that's a safety measure for everyone involved. So these are all safety measures being taken to make the hospital a very safe place to deliver. And I would actually dare say in times like this, especially at the UW where we do screen everybody who comes in, there's almost a second layer of safety there. If at least you're negative, and what's scarier is there is an asymptomatic component to this. And so in terms of pregnancy, how quickly pregnancy can change in the labor setting, and kind of given everything going on, I would even dare say it's probably a safer route right now, understanding the concerns that people would still have about hospital deliveries. But definitely it is the safe route at this point. And, hospitals are really taking a lot of precaution to make sure patient safety is first and foremost.
Great, thank you.
I'm getting a note from Dr. Shope wanting to circle back to the question about women of color, and not sure whether that pertains to the differential data on women of color and that impact. But there was another question that we received about the implications of health equity and if these are being addressed when doulas aren't allowed to join the parents, particularly when language barriers or other advocacy needs for clients of color may come up and they don't have their expected supports. There's been a lot of concerns about whether we plan to reintroduce, I think we kind of have to see how things go, but reintroducing, doulas into the visitor policy in the labor ward and so on. But this particular question came from someone who works primarily with doulas who are health advocates for marginalized communities.
Yes, do any of you feel like you can speak to that in terms of what your experience has been so far? I feel like we have a policy, and that policy is in place generally to be applied to all cases, and there are some things that come up on a case-by-case basis that we are always going to do our best to support patients and to accommodate where we can. I think it's a really good question, and it is one that deserves to be answered. And it's a hard one to answer because I'm not sure what each case is going to look like. Do any of you want to add to that?
In terms of the language barrier, which often is a concern, and we've actually taken care of patients with that and handled it, we do have our interpreter services, but we're also, if language were a reason or we need that extra support person, whether it be a doula, whether it be another family member who's been you know, part of the process and helping with the language and communication, we do have options for kind of zooming in or doula. So, you know, I mean, I guess what I'm trying to say is it's such a moving target. So that's number one. That being said, there's a lot of thinking outside the box to make sure that the safety is not compromised, but the support is able to be given. So it shouldn't be that safety replaces support, and that's absolutely not our goal. Our goal is for our patients to feel supported, cared for, and have the most optimal birth experience that they can have. But understanding we do have some limitations we're dealing with, we're really trying to think outside the box. And if it means giving a little extra time for counseling and making sure we have our interpreter services ready, that's been one thing. If it means that calling people in, you know, by phone to make sure they're communicating properly, I would say that if anything, we're taking extra precautions to make sure those other very important and necessary parts of care are not being compromised in the process.
Thank you.
We got a couple questions about precautions for pregnant healthcare workers. Could you quickly address that specific question for a target audience among us?
I can. I have actually a lot of pregnant healthcare worker patients. Mm-hmm. So it's a little bit challenging to figure out. When this first started, we looked at what can we do to give advice to our patients, and not knowing the scope of how bad the hospitals might have been overrun in this area, it was very challenging to know if there was truly a surge. Can our patients who are pregnant, who are healthcare workers, avoid exposures to COVID positive patients? Luckily, in Washington State, we have not actually ever exceeded our capacity in hospitals. And so I think it's really something that each individual person has to talk with their managers about to see, is there a possibility for them to have less exposure or to not actually take care of COVID positive patients, especially toward the end of their pregnancy? The other thing I have seen some pregnant patients doing, which is also a personal choice, is do they consider taking leave a certain amount of time before they plan to deliver to avoid exposure so that they wouldn't have the risk of being COVID positive at the time of delivery? And that's a very personal choice. There are financial implications for that depending on what kind of leave policies people have. So it's very personal. So I think technically the statement from the American College of OBGYNs says that if we're using proper personal protective equipment, pregnant women can take care of patients who are persons under investigation, which means we don't know if they have COVID-19 or not, or persons who have COVID-19. But thankfully in Washington State, there should be enough flexibility for pregnant patients to avoid that if they need to. That's not the same situation in other states in our country.
Great.
Okay. I feel like we're running out of time, but there's some really good questions. Perhaps what we could do is I could send these remaining questions out to the panel, and then we could compile some answers to send out to the audience afterward. There were several questions, though maybe this could be a concluding one just for this discussion, about transmission of COVID-19 to an infant through breastfeeding, and some concerns about having to, with all the precautions taking place, having to forego kangaroo care or skin-to-skin contact after the baby's born. This is a good segue into what we hope will be another discussion in a couple weeks through the whole U, another webinar, this time with our pediatrics faculty on newborn care. But any kind of initial recommendations on whether you could still breastfeed during this time of COVID-19 without any risk of transmission?
Um, yeah, so breastfeeding is breast milk. So let's start. There's two different things here. There's breastfeeding and then there's breast milk and giving breast milk. So breast milk is still a very safe, thing that is still believed by ACOG, which is our kind of like the American College of OBGYN. The studies seem to say breast milk is still preferred and safe if a woman were COVID positive and could still give that milk to her baby. We don't seem to see transmission through breast milk. Again, these are very early times, but that doesn't seem to be a process. If anything, there may be protection going through breast milk because you get antibodies, which help protect you from disease going through breast milk. The actual process of breastfeeding goes back to the fact that because at least at the UW, we're universally screening all women who come in, the good majority of them are negative. And so that's good. So if you're negative, then you know that you're not going to be in that scenario and risk. But if you were positive in that scenario, the recommendations, I think, are somehow to get the breast milk to baby. If it must be done through direct feeding, it's, standard hygiene. So wearing a mask, washing, trying to maintain as much distance as possible, wiping the breast before latch, kind of basic things of that nature. Possible further option is to actually pump and give the expressed milk to baby, and in that scenario it's using a one pump, your own pump, wiping down all the parts, keeping that part safe, and then potentially having a provider who is not infected feeding the baby. Again, this is challenging because sometimes when COVID hits, it hits a whole family, and that's not always an easy thing to do. So we completely are ourselves still working through this process of how do we safely do this if mom tests positive by chance, her partner is also positive, like how does this work? So there's not clear cut answers there other than trying to use common precautions that you can. But in terms of the actual breast milk going to baby, not only is it safe, it's actually still recommended and good for that to happen in the safest manner possible, understanding that everybody's family situation and scenario is going to be very different.
Thank you.
Yeah, thank you. Deborah, there's one more question that was asked a few times, and it probably would be relatively simple to address. I know we started just a couple of minutes late, so maybe we can go just a couple of minutes over. There are a few people that are not currently pregnant, but it's on the brain, and they're wondering if we would recommend that they pause or take a break in trying rather than risk the unknown.
Well, I actually think that Dr. Shope addressed that in a great way. I'm not sure if you heard that part, but I think we did get to that question.
Awesome.
Yeah.
Okay, there's some folks that may have missed it as well because it's been coming in more recently. But what we'll do is we'll go through all the questions, and what we didn't get to address, we'll try to disperse those questions among our panel and send out some Q&A following, maybe a little bit later today. We'll round up some resources about our telehealth program, our visitor policies, and other patient updates, and we'll send that out to the audience. Thank you all so very much for taking part in this panel and leading the discussion, Deborah, among our experts. Thank you all to the audience. Congratulations on your pregnancies, and to, for joining us for all this information. And I know it's a lot to take in right now. There's so much that we don't know, but to echo a lot of our leaders, we will get through this together. And the best way to be empowered is through information. So thank you for joining us today.